Hey everyone, it is Friday. It's time for our compilation video. We've been talking about arousal disorders this week. And really we've been focusing on issues with low arousal. There are some other conditions that deal with things like persistent genital arousal. That's a condition called PGAD, or now it's genitopelvic dysesthesia. And we're not going to talk about that condition specifically in this video. That's something that deserves its whole, own kind of video series. So, when you look at arousal, oftentimes it's something that is confused with sexual desire. Remember, those are two very separate things. Desire is the desire to engage in some sort of sexual activity with someone else, yourself, whatever it may be. It is mainly coming from the brain. It's an interaction between a couple of different neurotransmitters, and it is, basically that kind of first step in going from a sexually neutral position into more kind of sexual functioning. Arousal then is the physiologic response to that desire, and that manifests in a couple of different ways. You can have a physical arousal, kind of what's going on in terms of your genitalia, other parts of your body, and then you have kind of the emotional or psychogenic arousal, what's kind of going on in your brain to make you really kind of ramped up and feeling like, hey, let's do this. And these are things that they often work, or they have to kind of work well together to have really optimum sexual functioning. So if you have one that's not working well, it can throw things off. And you have issues where patients feel like they want to engage in sexual activity, they feel ready in their brain, but their body doesn't respond, or vice versa. So it's important to differentiate those things. So anyway, from a physiologic response standpoint, arousal is mediated by what's called the parasympathetic nervous system. So our body has two kind of uncontrolled nervous systems that we have nothing to do with. Those are called the autonomics. You have your parasympathetic, which is kind of your rest and relax and everything's cool and I'm not in any danger. And you have your sympathetic, which is basically your fight or flight response. So arousal is mediated by that parasympathetic response. Orgasm, on the other hand, is mediated by the sympathetic response. And we can talk about that sometime in the future. And so in order to have full arousal, a person has to feel comfortable. They have to feel relaxed. They can't feel in danger, things along those lines. And obviously some people say, well, what about people that engage in kind of more BDSM type stuff or things like that? And that, even though there is possibly pain or a sense of danger associated with that, what's going on there is that is a very, very safe environment, or at least it should be. And so you can have that enjoyment from that in sense of, danger or whatever it may be, but ultimately you're safe. You're not having to worry about your, performance. You're not worrying about your, life, things like that. So physiologically, when our body kicks into that parasympathetic arousal response, what we start to see, heart rate will go up, breathing kind of deepens, there's a little bit of, pupil dilation with that. We see something we really like. Blood starts going to places that it otherwise doesn't really go to too much, and so you can get genital engorgement. You can get, if you have breast tissue, that can be engorged. There can be flushing as the blood vessels on the skin kind of dilate, things like that. Obviously, in terms of female genitalia, what we see is a enlargement of the clitoris slightly. You see engorgement of the labia, and then vaginally speaking, what you're going to see is an increase in vaginal secretions, and then the vagina actually itself will kind of tent, or will kind of curve down like that, and to kind of help propel the cervix a little bit more forward. Now, all of those things working in tandem are fantastic, and that kind of correlates to that sense of physical, arousal. So obviously, if something is interrupting that can cause downstream problems. So take, for instance, you have a person who is worried, let's say they've had painful intercourse in the past, painful penetrative intercourse, we'll just say for ease of discussion. And so, they can be making out, they can be kind of having some foreplay, that's all great and good, they feel ready. But then if they start to actually be prepared for penetration, then that parasympathetic, that rest, that relaxed autonomic nervous system says, oh, I'm not supposed to be here anymore. This is danger zone. That sympathetic kicks in. And basically everything that I talked about, what goes on physically with arousal, switches with that sympathetic nervous system. So blood goes away from the genitalia. There's changes otherwise. And so that patient may experience then vaginal dryness. They may have, the muscles kind of tighten up instinctively to protect things. There can be decreased sensation to genital tissue, whatever it may be. So that's just kind of one example of what can go on, just with a fear response. Now, obviously, you can extrapolate that to other conditions where that are associated with increased anxiety about sexual activity. So something like vaginismus, we see, kind of that fear or with a pain with penetrative activity, or the anticipation or the fear of pain with that, really set that off. You can have, patients that have kind of I hate to use this term, but basically like a performance anxiety. They're worried about their sexual, engaging in sexual activity. How was my partner going to think? Am I good at this? Whatever it may be. And so then, they get out of that rest state. Now, obviously, there are certain medications that can do this. Certain blood pressure medications, certain antihistamines, things like that can make it really difficult for blood vessels to really dilate well, to kind of get blood flow to the tissue. And then obviously there are medical conditions, that affect this as well. High blood pressure is something that we see a lot of times causing genital issues with arousal. We see this in patients with penises that, a lot of times really bad, like uncontrolled hypertension or high blood pressure will lead to erectile dysfunction. Same type of thing can happen in patients with vulvas. So you can see, the decrease in blood flow to the area. You can see a decrease in clitoral enlargement or engorgement, and just the whole tissue is affected because it's just not getting that blood flow. Same with, diseases that affect kind of the vascular system on a very microscopic level, like diabetes. Diabetes, when it's uncontrolled, causes microvascular damage. It also can cause nerve damage, and that's another thing that we see too, with decreased sensation. If you're doing things and you're, kind of getting into that sexual activity, and then all of a sudden you're like, well, this isn't feeling right. I'm not feeling anything here. Like, I'm having genital contact, but I'm not getting any type of stimulation from that. What's going on? You want to look and see, is there actually a nerve issue? And so sometimes we'll actually get like a little, cotton tip applicator, little wooden, almost like a toothpick type thingy. And, you can kind of test the genital structures. Does this feel the same on like the leg versus here? And you can kind of map out, nerve patterns, and dermatomes is the correct term for that. And really see, okay, is there actually an issue with sensitivity from a nerve standpoint in this tissue? And if so, looking at that and trying to figure out, okay, is this more of a what's called distal, issue, like an end nerve type thing, just where that nerve terminates, or does it go back up, that nerve to more of a nerve root, all the way back up to the spinal column? You have patients that have spinal pathology, like a ruptured disc, or something going on with the annula, kind of like the kind of fibrous tissue cartilage kind of around the disc itself. And if that's going on, that can impinge on, that nerve. And so they have decreased nerve sensation there. So, you have to really kind of think outside of the genitals when you're talking about nerve issues, because obviously it can be that, but it can go all the way up to spinal column and even all the way up to the brain too. So it's important when you have patients that have physical arousal issues to truly try and figure out where is the cause of this. Is it local? Is it just kind of genital, or is it someplace else? So let's say we find something that we say, yep, there's issues with blood vessels here. This patient has long-standing hypertension, have a hard time kind of dilating that vasculature. What can we do? Well, you can use, the same type of medications you'd use for patients with a penis in terms of erectile dysfunction, sildenafil or what's called Viagra, and any type of medication in that class has been shown to be helpful for this. And this can be taken orally, or you can compound it into a cream just to apply to the genitalia. Usually they'll mix it with some other stuff too, like L-arginine or other type of nitrous oxide type dilating medication. And that can be applied, if you're using it with the cream, like 30 minutes prior to sexual activity. The medications orally typically take around 20 to 30 minutes to kick in, but they last for a little bit longer too. So you can kind of plan things out there if that's something you're struggling with. In terms of nerve damage, obviously if it's an actual issue with nerve impingement or, something pressing into that nerve, if you can correct that, that should help then the downstream nerve effects. if it's been an issue where the nerve has been severed or there's been actual, neuropathy, something like multiple sclerosis or things like that, it's a little bit of a trickier thing. There are some kind of experimental therapies out there using things like protein or platelet-rich plasma, hyperbaric oxygen, different types of other nutrients, supplements, things like that to potentially help nerves, regrow. Nerves do grow back. It's a very, very, very slow process, but they can. So, obviously if the nerve is getting entrapped or pinched, down at the actual pelvic floor level, doing something like pelvic floor therapy would be really good to help kind of reduce that and help improve, stimulation to that area. The other thing that we see a lot of times, especially is if patients have kind of some psychologic issues with arousal, maybe they've felt in the past that they shouldn't, touch their body, that there's, self-exploration, self-stimulation is bad. And so sometimes, trying to do some like guided masturbation or things like that may be helpful for those patients, telling them, okay, try and do this. And then that if a patient is able to become aroused on their own, that the kind of mechanics of it work. If it's just that they experience arousal dysfunction with a partner, then, okay, this is maybe something that we want to address from, either a psychologic standpoint or something a little bit higher up the chain. Speaking of which, when you talk about kind of more of that psychogenic arousal dysfunction, people not feeling turned on, even if their body is turned on, a lot of times you'll see this in patients that may have had some sort of traumatic sexual experience. They kind of disassociate, they go away to their safe place, and their body may respond properly, but they're not there in their head. And this can be really, frustrating for these patients. They can feel that it's there's something wrong with me. I know, like, I'm, getting lubricated. I feel kind of a genital swelling, but I'm just not there. My mind's thinking of all sorts of different things. It's off, in other parts of the world right now, whatever it may be. And so in looking at that, you want to address, things from a psychologic standpoint too. So, first of all, as a patient on any type of medication that may kind of inhibit some of those responses, different antidepressants will sometimes do this, especially some of the older antidepressants. We saw some issues with medications that can affect sleep quality, that can sometimes do this. There's a lot of different medications that affect sexual functioning when you're talking about medications that are altering neurochemistry. And so, it's something that if you've previously not had an arousal disorder and you're on a new medication and you're like, well, now I do, maybe something to talk with your provider about switching that medication. Obviously, patients that have had, traumas, we want to make sure that they're getting appropriate, counseling, psychological help to kind of deal with those traumas, because that can be something that even if it happened years and years and years ago, it can still affect things, with your current relationship. Even if things are better, you're the different partner, whatever it may be, those traumas can have an existing and a lasting impact on things. So the other thing to think about, and like I said, yesterday, which I'll probably do a whole video on this, is, conditions in the whole neurodivergent spectrum, or even things like ADHD. ADHD for adults is something that, I think we may have known existed, but no one ever talked about it, or, we're really just figuring it out, and it may be because, the current, those of us that have been doing medicine for a little bit, we're getting to the point now where, we were the generation that, ADHD was kind of a bad stigma. It was just, you were just finding out about it. But really these were, kids that were kind of bouncing off the wall or couldn't pay attention or whatever. And maybe they hush took Adderall or something like that, or Ritalin. But now it's something that, those of us, especially as adults, may have found coping mechanisms. But as we get older, sometimes those coping mechanisms fail. And so we find that these, kind of more attention deficit type issues come into the forefront. And this can affect sexual functioning too. Patients that are say like, oh, I can get aroused, but I just can't focus on what's going on at all. Or I had a patient, who, she said all she would do is she would just be thinking about the laundry and, what she had to do around the house and, is going on with family, and she's like, I can go through the motions and, things respond, but I'm not there emotionally, and that's bothersome to me. So definitely something to consider, doing some therapies for ADHD if that is something that is affecting you. And there is a screener you can take online. Basically, it's an adult ADHD self-screening resource tool. You can just type into Google, adult ADHD screener and kind of see. And like I said, so for some patients, this medication can be life-changing. It can really affect things if you do have that. So otherwise, it's arousal disorders are something that are very, very common. Not as common as desire issues, but, if they're there, you definitely want to treat them because, like you said, you can have all the want in the world, but if your body's not responding, it's a very frustrating thing, and it can lead to then decreased desire because you're like, well, I'm not responding. Well, why am I doing this? So anyway. Well, that's about it for today. Thanks for watching. Obviously, hit like and subscribe if you're at this point. And feel free to share this video with your friends or colleagues. And obviously, if you have any questions about this, I'm happy to answer them. If you'd like to talk to someone about this from a clinical standpoint, always happy to do that. You can check out my website at www.havencenter, that's HAVENCENTER.com. Otherwise, have a wonderful rest of your day.